I wanted to teach you something that's really near and dear to my heart, and that's treating special needs patients. And we've got some objectives tonight. One is to identify barriers to care. How does your state compare? Behavioral risk, children versus adults, autism spectrum, non-sedation techniques to help you treat people, using anxiolytics. We've been doing that for a long time, using benzos, narcotics, and using them safely, using reversal agents, basic pharmacology, degrees of sedation, how to use CRNAs and mobile anesthesia providers, and then special care organizations, and then how to continue your training. So this really started back in 2013 with a couple partners that wanted to take mobile dentistry to autism centers. And it really intrigued me because I like doing short-term mission trips on mobile dental units. So in 2013, we actually bought a 40-foot trailer and equipped it with 2 operatories. And we took it to autism centers and day centers. And we saw just a whole lot of patients. We had a full schedule because if somebody didn't show up, we just went inside and got another one. So it was really amazing. After about 5 years, the mobile unit started breaking down. And so then we were able to go to a brick and mortar location here in Nashville. And we've got 5 rooms, and they're built so that we can sedate people and move around. So they're pretty large operatories. Definition of special needs patients, individuals with physical, developmental, mental, sensory, behavioral, cognitive, or emotional impairment. Anything from Down syndromes, people that have been born with fetal alcohol syndrome, Fragile X, cognitive impairment, disabilities, emotional impairment. There's one more special needs patient that I didn't have a good slide for, but that would be your neighbor that has experienced PTSD or some kind of oral trauma in the past and is scared to go to the dentist. And, it seems like in our society, there's more and more people that have anxiety disorders, and more people are putting off dentistry. So learning how to talk to people about anxiety disorders and having some tools in your toolbox, things from non-sedative techniques to sedative techniques, is really important, especially in the world that we live in. This is, I asked ChatGPT, what are the top disabilities in our population, trying to get the latest information. And some of this slide, most of it comes from Wikipedia and a few studies. But the number one is this kind of idiopathic, we used to call it mental retardation. Now we would just call it an intellectual disability. The second most common, which is what everybody is hearing today, and in the government and with Robert F. Kennedy, of course, is autism. And it affects anywhere from 1 in 32 babies to maybe even 1 in 20 some. Then genetic, environmental, cerebral palsy, Down syndrome, X-linked, Fragile X, SYNGAP, and then Fragile X variants. And in our practice, 90% of our patients are special needs, and 10% are family members and caregivers of those special needs patients. So we have one from each of these categories, which is really amazing. This talks about the top 10. These are the findings. But I think this is what, when we think of folks with an intellectual disability, this is what we think of most, and that's your typical neighbor's child with Down syndrome, also called trisomy 21. It's caused by a third copy of the chromosome 31, and occurs in 1 in 1,000 births worldwide. So about 5.5 million people. And we've all known people like this. We've all had patients, friends with children with Down syndromes. And if you've been fortunate enough to know some of the adults, they're really remarkable and really able to do a lot. So there's also these things called Fragile X, and this is kind of it's a moderate disability. It's caused by a mutation in this one FMR1 gene on the X chromosome, and it manifests as autism and kind of a intellectual disability, low IQ. The prevalence is 1 in 4,000 females, 1 in 5,000 males, and you get some autism-like behaviors. The next one that I know that you guys have seen a lot of, and that's cerebral palsy. This is the thing that happens when children are deprived of oxygen at birth. It can also be due to lack of a nutrient or lack of a specific protein. But cerebral palsy patients are the one that we're pretty familiar with. They have issues such as seizures. So many of them are taking anti-seizure medication. They have vision and hearing problems, speech difficulties, and of course, most of them are in their wheelchairs and spend their life in a wheelchair. There's lots of management for these folks, from automatic wheelchairs, therapies, medication, surgeries, and there's no cure, but early intervention improves independence and quality of life. The other thing that I've learned about cerebral palsy patients is it's not really, it's a disability, but it may not be an intellectual disability. In other words, they may be very smart, they just may not be able to communicate it. So when I have patients with cerebral palsy, I always speak directly to them, and I don't assume that they don't understand what I'm saying. You know, I would never talk down to them or assume that they didn't understand what I'm saying. Autism spectrum disorder. Now this is getting a lot of press lately. It's a neurodevelopmental condition, and it's thought of having a way that understanding it as the way a person is wired, in that their thought processes don't conduct normally. So there's a wide range of abilities and challenges. There's so many difference. You know, they used to just call it that person's autistic, but then that really didn't address it. And I've had patients that are mildly autistic, and I've had folks that are severely autistic. I've had folks that were brilliant and got through college and got a PhD in biochemistry, and now are doing cancer research up in Wisconsin. And I've had patients that are so disabled they walk around the dental office and it's hard to get them to sit down, and they're not communicable. Early identification and support is really critical. A lot of universities have really good intervention for family members with autism. In fact, Vanderbilt's got a center here called the Kennedy Center, which is really amazing because it addresses autism, and they start at about age 3 and then come all the way up through high school with a variety of programs and interventions, including, of course, diagnosis early on. Core features are difficulty with social skills, repetitive behaviors, restricted interests, and then being really sensitive. You know, when I look at autism patients, not only are they hard to sedate in the dental office, but things like the Cavitron just drive them crazy. I don't know if you've experience that, but you can be cooking along just fine and then pull out the Cavitron and then they just flip out due to some vibrations or the sound or the something of the Cavitron. It's kind of like the handpiece doesn't bother them too much, but boy, the Cavitron really gets them going. We've got some folks with these rare syndromes like Noonan's conditions. It's a genetic condition affecting growth and development. It has a special appearance, which is this kind of the long face syndrome with the wide set eyes, low set ears. The thing to watch out for if you have any patients that you're working on are these heart defects and being able to understand either getting a cardiology consult or being able to monitor their heart is important in treatment. And of course, there it says cardiac monitoring and treatment, growth hormone therapy, education, and developmental support. It's a lifelong condition, but early diagnosis is key. Here's another one. This was on our sheet. It's called a SYNGAP1 related disorder. It's due to a change on the SYNGAP gene. It affects brain function and development, results in developmental delays, intellectual disabilities, epilepsy, seizures, some autism traits, and then some hypotonia and motor delays. It's inherited, but it's not inherited every time. In other words, it's not a sure thing that a parent with a SYNGAP disorder will pass that along. So that's kind of interesting. Most of the intellectual disabilities are these things we'll call idiopathic. And we all know what idiopathic means, no identifiable medical or genetic cause. But we have folks like this. This is one of my patients. Accounts for the largest proportion of ID cases, features delays in learning, reasoning, and problem solving, challenges with daily living skills and social behavior. And there's wide variation. You know, you can have someone that's mildly disabled and folks that are profoundly disabled. Diagnosis is based on standardized IQ, adaptive behavior. So now that we have identified who the special needs patients are, let's just talk about for a minute, let's talk about dental access and expenditures. So I don't know how it is in your state, but in the state of Tennessee, there is good care for intellectually disabled people up to the age of 21. We have 4 major cities, Memphis, Nashville, Knoxville, and Chattanooga, and they all have good health care in each of these cities. Regarding the children, the pediatric dentists do a wonderful job of taking care of kids with special needs, and most of them participate in the federal Medicaid program. In Tennessee, we have what we call TennCare. But the problem is when they turn 21, they kind of drop off because either Medicaid doesn't cover it anymore or they're shifted onto a Medicaid program that has less benefits. And so in Tennessee, for instance, TennCare will cover the cost to take a child to the hospital and do a bunch of restorative treatment, a bunch of stainless steel crowns, and they'll cover the facility fee, the hospital fee, the cost of the doctor, and the cost of the anesthesia. But when they turn 21, they won't do that anymore. So when these special needs folks turn 21, they can be in a crisis situation. So that's a place where you can help. This was a good article called Dental Access and Expenditures for Adults. It's based on 2017 data, but it's in the Journal of Public Health Dentistry. And basically what it said was, if you look at the results, it says adults with intellectual disability have 3 times the odds of being unable to get dental care and 3 times the odds of having to delay necessary dental care compared to adults without disabilities. I should have highlighted that one. So that's a problem. So it's saying that they have a 3 times harder chance of getting the appointment and 3 times the odds of having to delay their necessary dental care. So that was a really good study. Let me show you another good study. This is by the Harmony Health Foundation, and they came to Tennessee a couple years ago and did what they call a mystery shopper program, where they interviewed practices and asked them if they had new patient openings. And of course, everybody has an opening for a new patient. But then they said, well, if the patient is a special needs patient, do you have an opening for a special needs patient? And then the number of yeses went down. And then they said, do you have an opening for a special needs patient that's on the Medicaid or the Medicaid waiver program? And in those cases, they got a terrible response, which was, no, we don't have any spots for them, or no, we can't see them. So this is a good report. It's on the Harmony Health website, and they did a report on West Virginia, Tennessee, and as they go to these other states, they're coming up with other things. In their mystery shopper program, they found out that individuals with IDD face significant challenges. They did multiple states. And then here's the data. Let's see. In Tennessee, this was for Tennessee. The number of days to get a first visit was 62 days to 64 4 days. So right there, you have totally ruled out any kind of emergency treatment. Even among the safety net clinics. One of the issues is we have these federal, state, and city clinics staffed by dentists and hygienists and assistants that work for the city, the same thing that works for the state, the same that work for the federal government. But other than doing a look and see on our special needs patients, they can't do very much. So how do we do it at our office? You know, I've been doing this for more than 30 years. I had the privilege of doing a general practice residency at Vanderbilt back between 91 and 93. And I got to rotate through the hospital, and every Friday we had the opportunity to take special needs patients to the operating room, and Medicaid would pay for it. So on these Fridays, we would line up 3 or 4 patients, go in, do a complete exam, full mouth series, do all the fillings, root canals, extractions, and then some stainless steel crowns or anything that we could do in one visit. And we had great outcomes. And it really didn't matter what the degree of difficulty was, because we had a world-class anesthesia team. And they could be mildly disabled and we would see them, and they could be profoundly disabled and we would see them. The anesthesia team was amazing. That all stopped about 10 years ago when Tennessee went on their managed care system, and then they phased out their hospital coverage and their approvals for adults over 21. It's like the magic cutoff line. So when we started doing this in the private clinic, what we came up with is a principle statement. And what if we can assess the patient's level of disability? Can we implement appropriate treatment modifications and medication management to enable them to have normal dental exams in the hope of restoring oral health? So the way we do it is we try to classify people into 4 categories. Category A is people that would benefit from desensitization. That would be a non-sedation patient. Category B, which would be a patient that needed some help, and that could be an anxiolytic, it could be nitrous oxide, or it could be oral sedation. Then we had the folks that are more moderate to severe, and those are folks that would be an IV sedation patient or a combination oral sedation, IV sedation. And then category D would be if nothing else works, then they're going to need general anesthesia to be able to do an exam, x-rays, and take out teeth. I'm going to jump to a couple of videos. I think we're doing good on time. There's a lot of good stuff here, but I'll jump into this video.
Let's see how this fits.
It's really special being able to work with the special needs population.
Good oral health is a good predictor of good overall health.
Okay, open.
There's such a correlation between nutrition and overall health, which translates to dental health and overall health, and lack of oral hygiene and overall health.
Among this population, we're seeing a lot of patients that have high sugar intake and high acid intake.
I've treated this patient population in 2 different states, and one of the biggest concerns that I have with what I'm seeing in Tennessee is the nutrition aspect of it.
Acids and sugars are the worst things for teeth. So among the developmentally disabled, we need to reduce the amount of sweets that they consume.
Like them? They look pretty good.
Among adults, the leading cause of tooth loss is periodontal disease.
Teeth becoming mobile over time, the tartar being built and caked onto the teeth and not being removed or debrided properly.
So it's important not only to clean your teeth at home, but to have them professionally cleaned so that you can have the bacteria removed that you can't reach.
That's really good. Can you get the inside?
And we recommend that they brush their teeth 3 times a day. We recommend after breakfast, after lunch, and before they go to bed. This gets the bacteria off the teeth at night when they do the most damage.
Okay, turn the water on. You're doing all right.
A lot of people are able to do it with either a manual toothbrush or what we recommend is an electric brush.
I think the most important thing that may be overlooked, and it's just kind of a small little task that takes very little time after every meal, just to simply kind of, wipe their mouth down of any food debris.
Even if it's baby steps that are taken to get to that point, it's very important to try our best to get to that point.
Now, how does that feel?
Oh, it's good.
Feels awesome, huh?
It sure does.
Now give me $1 million smile.
It's funny. I think that those patients are still in our practice. The doctors have moved on. That was made, 7 or 8 years ago. But the thought is the same. So let me move on to a couple of things here. Let's see if I can get on to the next one. So as we talk about what are some accommodations that we can make to allow folks with disabilities to be seen in our dental office? So one is just to keep them in their chair. So if you can move your dental chair out of the way and position them under the light, then having a wheelchair accommodation like this actually works. And this is one of the expanded function assistants cleaning a patient's teeth. And it worked really well right there. Another one is this Hoyer lift. And these things are not hard to operate. You can watch a YouTube video, but it's amazing. It just uses a hydraulic thing to pick them up and put them where you want them. So watch this. I think there's a video. And our staff has gotten really good at doing this. It's really gentle. There's like no way to crash it. And folks come in all different sizes and shapes. But watch how they land. Watch how the assistant lands this patient. I mean, that is sweet. That is just a sweet,
Softest landing I've ever seen.
yeah, softest landing I've ever seen. So let's talk about some other things that we can do. So this is what we use in all our operatories. And I don't know how many of you hate rubber dams, but if you hate rubber dams, get one of these because you'll never have to use another rubber dam if you have this. It's also great with surgery because it blocks the airway and you don't have to worry about people swallowing teeth, swallowing roots, swallowing wisdom teeth, or anything worse than that. But this is the
Shield
dry shield.
DS1 onto it. Place it back on the toolbar. You have now converted your room into a dry shield room. Select your mouthpiece. Select the correct mouthpiece size to ensure a proper seal and for your patient's comfort. Prior to insertion, spray a mixture of air and water on the outer surface of the mouthpiece for moisture. Also, spray the inner lining of the mouthpiece for additional lubrication. Slide the mouthpiece onto the DS1 by rocking it back and forth until it locks into place. Dry Shield is the newest innovation in dental technology that creates a better overall patient experience and reduces your procedure time. The soft, smooth, and flexible mouthpiece is specifically designed for patient safety and comfort. Dry Shield helps keep the working area dry and visible by continuous, uninterrupted suctioning while keeping your tongue and cheek out of the way. Dry Shield also acts as a safety barrier, protecting your airway from potential particles and debris. With Dry Shield, you will not have to strain to keep your mouth open. You can now simply rest your teeth comfortably on the bite block. The key to Dry Shield is to always breathe through your nose. This will ensure comfort and relaxation throughout the appointment. First, turn the lever on. Before inserting the mouthpiece, fold the tail towards the center of the mouthpiece. Next, fold the sides together. Ask the patient to open their mouth while reminding them to focus on breathing through their nose to promote relaxation. Slowly insert the mouthpiece lining up the front edge of the bite block with the distal of the canine. Then let go of the mouthpiece, letting it adapt to the oral cavity. Use finger pressure to adapt the cheek retractor along the inner surface of the cheek. Adapt the top of the mouthpiece to the palate and the bottom of the mouthpiece to the floor of the mouth.
So it's really good to watch that video before you try to put one in, because I just tried to put one in today and didn't do it right. And the guy started gagging and set up gagging. And I thought, yeah, I didn't fold that one. I need to let the system do that. So Dry Shield is very similar to the Isolite. You know, they've got the Isolite system, which has the light on it and does the same thing. And I think there's one more. But this is a must-have in our office. I mean, you can go so much faster with drilling out amalgams or doing crown preps. If you've got the patient comfortable back in the correct position and you have this in here, man, you can go to town.
The narrow portion of the mouthpiece.
So let's move on to other.
Shield DS1 onto it.
Okay, there we go. Okay, so another great technique that I've discovered, I've had Shofu products in my office for 30 years, but I've never seen this. This is called Fit SA. It's a bioactive, self-adhesive, flowable restorative. And look at this, it's self-adhesive, meaning you don't have to etch and bond. Watch how easy this is.
So this is an example of using Shofu's Fit SA for a class 5 restoration. It's self-adhesive and releases fluoride. It's amazing. So here I am, just get a good clean prep, dry it off really good, put the Shofu flow in there and light cure it, and then polish it down. It works great. And really what I'm using it for is I'm using it if I have a patient that's moving around a lot and I've got a small class 3 composite to do, or if I have an air bubble and a composite or a margin repair, so I can go back and drill out the open spot in the margin and flow this in, hit it with the light, and then I'm done and my margin is cured. Now in this one, in this situation, I'm adding a second layer, and then I'm going to light cure it, and then after light curing it, finish it down with the EF6 burrs, and the shofu polishers, and then I'm done. It makes a really nice restoration.
I used some today. I'd done a crown prep and was ready to scan it, and the assistant got me and told me there was a defect in my scan. I said, "What do you mean there's a defect in the scan?" He said, "Right there." I said, "Oh my gosh!" And it was an air bubble. It was an air bubble at the margin. So I just grabbed the Shofu Fit SA and squirted just a little bit in there and hit it with the light, and boom, I was
This is an
done.
example of using shofu.
So let's talk about non-sedation techniques. If you're kind of into holistic dentistry, you could consider doing multiple visits or gradual desensitization, and this would be introducing treatment gradually, bringing the patient in the office, walking them around the office, setting them in the chair, sending them home, giving them a reward, building the patient trust, a family member talking to them about what's going to happen at that visit so that they're prepared for it. You could also have desensitization items like these balls that have these things on them for them to hold on to. You could also give them squishies, anything like that, anything that helps you build patient trust. It's a good non-sedation technique. You can also use positioning devices. So I don't know how many of you we've all heard about using rainbow wraps and Velcro restraints. And so I don't think all of us have seen it. This is something that you probably saw in the pedo department, but that was probably it. But it's got a lot of benefit. So this is called the rainbow stabilization device. Let's see if it comes on here.
I'm Dr. Shirley Spader-Friedman. As you know, while performing dental procedures, you're working in tight, small, dark areas. So imagine if you have a patient with an involuntary movement disorder, and you really want to provide the most safe and comfortable environment for your patient. Well, Specialized Care Company provides products such as the Rainbow Wrap and the Rainbow Board, designed to do just that. Additionally, it helps to mitigate the risk of injury for both your patients and your staff. While you're on the website, please refer to the easy-to-use tools to help you make the best selection for your patients.
That comes from Specialized Care. I tell you, another good one though is what we use. A lot of autistic patients respond really well to weighted blankets. So you can get this from Dental Calm, and it's a giant weighted blanket. It looks like it's got lead weights in it. There's also your lead apron. So if I've got a patient and they're moving their hands around and they're just kind of mildly disabled, we'll get the lead apron and put on them, and then all of a sudden their hands, stay still. And that lead blanket or weighted blanket is very comforting to them. Another way to do non-sedation dentistry is to do this thing called behavior management. And this is actually in the CDT. It's code number 9920. It's used when a patient's behavior requires extra time, attention, or personnel to safely deliver dental care. This is one that we kind of worked out a deal with our managed care provider who didn't want us to sedate all our patients, but we said, we can't afford to do, $120 pro fees or $140 visits on these folks when they're going to be there for an hour, hour and a half. So we came up with this code called 9920 and got it approved. So our federal Medicaid program will cover behavior management. Now this is worth the whole course right here. It's called code 9920, and in Tennessee it pays about $101, and it's every 15 minutes. So if I have a patient that is going to move around a lot, we'll charge a 15-minute an extra $100. Or if I have to pay another assistant to come over and hold their hands, while we clean their teeth, then we're going to charge the behavior management fee. It's really good for mild disabilities if you don't need to sedate them. Clinical example would be a patient with autism that needed a bathroom break. People just get nervous and they got to get up and go to the bathroom right in the middle of your treatment. Or you're about ready to get your impression or your skin and they say, oh, I gotta pee. Okay, we'll go pee. And then they're in there for 15 minutes. Well, you should be able to charge for that because that's 15 more minutes of chair time while you wait for them to do that. And you can use behavior management to do that. This was a great slide. I debated whether or not to send that to my wife. I think in the end I did not send that to her, but it's there for you if you need to send to somebody. When we have a patient that we think will need some level of sedation, rather than bring them in for a comp exam and x-rays, which most likely will fail, we bring them in for this thing called a sedation consult. And it's in the CDT as a 9219. And this is just a chance to sit down with them for 30 minutes to an hour and find out, what's your history with dentistry been? Did you go to the dentist as a child? What was that like? Did you ever have nitrous oxide sedation? Did you ever do the oral sedative? Did you ever do the nasal sedative? What was that like? Did your family member have to go to the hospital and have hospital dentistry? What was that like? What was it like getting your wisdom teeth out? What has your physician said? You can get all this information and do it under this code called a 9219. And your assistant can get most of the information and then bring you in. And by doing the pre-screening, they can say, oh, doc, this one's a wild one. I think you'll have to sedate this one. So when you come in and you meet them and talk to them, you're automatically trying to decide, am I going to do this as a preoperative sedative case? Am I going to do it as an oral sedation, or is it going to need IV sedation? So you can come in and do that with this code. Anxiolysis is a very light form of sedation, and we've been doing this a long time in dentistry. It's talked about in the CDT and also in the TCA, the TCA meaning the legal code for Tennessee, and they have rules for it about using anxiety medications. So if you remember, in the old days, we used to use Valium, and it was usually 10 milligrams the night before and 10 milligrams an hour before. But it's got a long half-life. I mean, it's got these metabolites that hang around for 20 plus hours. So it's not a good drug for the dental office. Better drugs for anxiolysis are lorazepam and triazolam. I kind of like, for mild cases, I like lorazepam because it's faster on and faster off. So 1 milligram or 2 milligrams 30 minutes before seems like the ideal dose for anxiolysis. If you have a special needs patient that is not driving to the office and you're sure of it, after you've gotten informed consent, you can write a prescription for that and have a family member give it to them when they leave the house. And they'll be just about perfect when they get to your office. Triazolam, you could do the same thing after you've signed a consent form that someone will bring them, stay with them, and be responsible for them. And it has a half-life of 2 hours. Now, what I've learned on both of these medicines is you get kind of the peak plasma effect after 60 minutes, and then it starts to go down. So if you're going to do something, if you're going to treat them, you need to treat them within 60 minutes of giving them an anxiolysis. This talks about diazepam, what it is. It works on the GABA receptors. We've all seen that. It's been around for a long time. The problem with using IV Valium is it causes a lot of phlebitis. So I don't know if you've ever if you've ever given it in an IV, but back in the old days, we used to do Valium and Demerol and put it in an IV. And if you didn't water this stuff down, man, it could make a vein red and irritate and itch and burn and all that stuff. It really looked awful going in. And also it had like propylene glycol in it. Who wants to put propylene glycol in their body, right? So better medications came out. This is one that came out, I'd say 20 years ago in dentistry, called Halcyon. We used it in the hospital a lot. If we had a patient that wouldn't sleep, we'd just go up and give them a Halcyon at night. So I'm very familiar with it. We started using it in dentistry about 20 years ago. It's a great sedative. It's best, in my opinion, it's best to use it in the office. It's considered low dose, so 0.125 to 0.25 can be considered anxiolysis in the state of Tennessee, meaning you don't have to have a sedation permit to prescribe it. But when you get up to 0.5 or 2 triazolams, when you do 0.5 milligrams, then it's considered an oral sedation, and so you would need a limited conscious sedation permit to use it. It's really an ideal because it's fast on and has a short half-life. It puts this person to sleep. It says here in about, I would say it works really well in about 60 minutes, and then it starts wearing off. Another really good one that we talked about is Ativan or lorazepam, and it's been used a long time in medicine. In fact, I think my grandmother used to have a prescription for this, and she called it a nerve pill. So I'm familiar with that. Nitrous oxide has been used a lot. You know, it was invented back in the 1800s. It seems like Horace invented it. It's been used a lot. We've all had good experience with it. This is what it looks like on the chemistry chart. Nobody really knows how it works. If anybody knows how it works, please put it on the chat box. But it goes in, it goes out. There's no residual. There's no breakdown products. It seems to work really well. It modulates a broad range of ligand-gated ion channels. There we go. And slightly potentiates the GABA and glycine receptors. Now, I know from personal experience, if somebody puts you in the dental chair and gives you too much nitrous oxide, it's like having the bed spins. I mean, it really can make you sick to your stomach and make you never want to use it again. And that's probably what happened when I was in dental schools. They probably gave me so much they wanted to make sure that I never, ever, ever, ever abused it. So I've never, ever, after dental school, I never, ever used it on me and never, ever had a desire to use it. Having said that, when I was looking at peer-reviewed studies globally, I saw some reports that said that the best sedation technique is a combination of an oral benzodiazepine and then nitrous oxide. So if you have a patient that's special needs, mildly to moderately disabled, that you want to sedate, it's a really easy technique to give them a 0.25 milligram triazolam 30 minutes to an hour before, bring them into the office, and then right before you start giving shots or something, put the nitrous oxide nose on there and dial in some nitrous. So it's a combination. You're going by 2 different routes. You're doing the GABA receptors, and then you're doing gated ligand channels. And using that together has profound analgesia and light sedation. So let's go up to something that I'm very familiar with, and that's oral sedation. So I first started out using oral sedation 30 years ago. And this is what the pediatric dentists have been doing for a long time. given the midazolam syrup. It's 0.25 milligrams per kilogram. And I put a limit in our office up to 20 milligrams. So we don't give more than 20 milligrams to an adult. Now in children, you've got to do the math. You've got to figure out the kilograms and then the milligrams and make sure that you dose it correctly. But the onset's in 30 minutes and the effects lasts from about an hour after you give it to about 90 minutes after you give it. It wears off pretty fast. And the great thing with oral midazolam is it's reversible. So if you were to have a problem with someone that was super sensitive to oral midazolam, you can reverse it with a single shot. And I meant to put sub-Q in here, but you can go sub-Q or IM, flumazenil, in the deltoids. And it takes about 5 minutes for that to work. And then it kicks those midazolam molecules off those GABA receptors. This is what it looks like. It comes in 2 milligrams per ml, and you can put it in a 10 cc syringe, and so 5 cc's is 10 milligrams, and give that to them. Let's go back and talk just a little bit more about this. The pediatric dentists are experts at using this, and they also use the Versed and use it as a nasal dropper. So they make these little nose things that you can put in their nose and then drop a couple drops of IV Versed in there, and then it will sedate. So this technique of using oral benzos like midazolam and nitrous oxide is a really sweet technique. You'll have folks that you can get them lightly sedated, but you can't get them sedated enough to pull a tooth on. And for those, you may need to up it to IV. So IV works really well. We use peripheral IVs. If you remember going to the hospital, it's always started in your hand. I think the hand veins hurt the most. I think the antecubital fossa is a better place to start an IV. And if we have someone that's a cerebral palsy patient, don't give up on the arm. If you have to give up on the arms, go down and look for a foot vein. So oftentimes we'll start a 24 gauge IV in a foot, and it works really well because a lot of patients don't move their feet real well. So the technique is we connect the IV to a 500 cc saline drip. I usually titrate the fentanyl first, which is usually half a cc, which is 25 micrograms. Then I wait for it to work. Then I titrate about 2 to 2.5 milligrams of Versed, and then wait for that to work. Almost never get oxygen drops. Now, why would you give a narcotic with a benzo? And I can tell you why. Because if you look at the sedation curve, the effective sedation curve on Versed is up and down. It's just like a sine wave. So 15 minutes, you get really good sedation, and then it drops off really fast, and then you have to redose, and then back up again, and then back down again, and back up again, and back down again. You can flatten that curve by using a narcotic like fentanyl, and it just flattens that benzo curve so that you don't have to give as much benzo. I think it's a really good technique. We give almost all our patients, we start an oxygen cannula. If it's a young college student and we know that they're not going to need the oxygen, then we don't always put the cannula in there. But we always have it hooked up and ready to go. So all the rooms that we use have nitrous and oxygen, and we can plug a cannula in there and give it to them. And of course we can, if we ever get them too deep on the sedation curve, we can always adjust it with 0.1 or 0.2 milligrams of flumazenil. It's real easy just to put that in the IV line. Almost never have to do that. This is Versed again. This is what it looks like on the chemistry, 3-dimensional. It can be given, as we said, by mouth, IV, or injection even into a muscle, spraying into the nose, or here it says even through the cheek. It begins working within 5 minutes. In its half-life, I think it's about 2.5 hours. Good, I got that one right. It's a short-acting benzo with elimination half-life of 1.5 to 2.5 hours. The effectiveness is only about an hour. It's metabolized by the cytochrome P450 enzyme. So this is the same enzyme that's associated with grapefruit juice, and that's why you hear all these people say, well, they can have whatever they want to drink except for grapefruit juice. It's something about this cytochrome P450 enzyme. Fentanyl is a synthetic opioid, primarily used as an analgesic. It works really well. I see that my time is running out. This is naloxone. This is what it looks, Narcan. Almost never have to use Narcan on a patient because I think it's good to have a little bit of opioid, have them leave with it. I mean, it makes them feel good. And once they start to wake up, why would you want to take away the good feeling that they have? So I think, especially after wisdom teeth extraction, it's good to leave the effects of the fentanyl in there when they leave. This is our sedation record right here. You want to keep a time sedation record, whether you do oral or IV. You want to get pre-op stats over here so that you know what your baseline is before you've ever given them anything. And then you want to monitor them. For oral, it's every 10 minutes in Tennessee. For IV, it's every 5 minutes. And then you want to sign them out with this Aldrate scoring system. And we can talk about that one later. If nothing else works, then you can consider general anesthesia. And there's different ways to do that. That's the pretty slide that they show you in the textbooks. Here's the slide in our office. It's not so pretty, but we can do it. And we use an anesthesiologist. Thank God that dental anesthesia became a specialty because you can have a mobile anesthesia team come out. It's usually a nurse and an anesthesiologist, and they can use propofol. They can use sevoflurane, isoflurane, all those good things, and they can take care of your very disabled people. Let's quickly talk about dentist risk tolerance. This is a great slide. When a dentist administers sedation, their risk tolerance is determined by factors like patient health, sedation type, training, and the practice's protocol. The dentist balances a patient's need for sedation against the potential for complications. Their professional obligations and legal liabilities reinforce a standard of care that prioritizes patient safety. So only you can determine what your risk tolerance is. I'm going to speed through these challenges, institutional barriers. If you'd like to get additional training, if you think, hey, I'd really like to try this, I'd like to do more than anxiolysis. Dr. Randy Pigg at Conscious Sedation Consulting is an inexpensive way to learn it. He also teaches IV. You can do like 4 weekends in different cities, and you can get the number of hours. I think in Tennessee it's 60 hours of clinical sedation in order to get your license. There's also DOCS. DOCS is excellent. You can get training in adult oral sedation, IV sedation, dental team training. They also do, of course, ACLS. My favorite group to belong to is the American Dental Society of Anesthesiology. And we have a course in Chicago coming up in December. You can split off and do either general anesthesia and deep sedation, minimal and moderate. You can take a team member and do the assistant course. It's a 2-day great sedation course for assistants. It's a wonderful, and you get to stay right there on the Lake Michigan in Chicago. This is a Special Care Dentistry Association. This is the American Academy of Developmental Medicine and Dentistry. One inclusive voice, great organization. This talks about the mission is provide a forum for healthcare professionals who provide clinical care to people with IDD and improve healthcare and outcomes. This is the Shofu Special. I just put that in there. This is my contact information. I'll come back to that one. Sedation dentistry and being able to take care of special needs patients has intangible rewards. And then from Proverbs, trust in the Lord with all your heart, lean not unto your own understanding. In all your ways acknowledge him, and he'll direct your paths. So with that, I just want to say thank you for your time and for letting me give this presentation.
All right, we will go ahead and open it up to questions from the audience. Everyone, this is a great time to get your questions answered. You can type those into the Q&A box. And Dr. Vaughn, we do have a couple already. So
Okay.
what are the desensitizing techniques you use for proprioceptive sensory issues, pedo patient?
For the pedo patients, and it's the desensitization is bring them to the office and let's walk around the office and see everybody, meet everybody, see the chairs. Let's sit in the chair and see what that's like. Let's get you a toy. Let's get you a toothbrush. Maybe practice brushing your teeth. And then we'll bring you back for another appointment later. But we'll have a desensitization appointment where it's just come in and walk around the office and meet everybody and have fun.
All right. And another one is why the codes, why D9219 versus 9310? Is it because you will be the delivering provider?
I'm not sure. I think there's a case management fee, and then there's a I'm not quite sure. I'd have to look those two up.
Okay, and a bunch of thank yous in the chat. And let's see, one other question just came in. Special needs patients are more than just developmentally disabled folks. The VA, for example, frequently treats injured veterans who need special accommodations.
That's a good point. I think you're right. And also, just wanted to point out that there are a lot of folks that have not been to the dentist because of anxiety issues. And so anything that you can do to alleviate anxiety will help them get the dental care that they need and want.
Another question, have you had to consider any additional treatment modifications when caring for aging patients with special needs?
That's a great question, and the answer is yes, especially if you're dealing with patients with dementia. So if you have someone with either Alzheimer's disease or significant dementia, their physician will say, hey, we don't want you using benzos on Miss Johnson. So you can do some modifications, such as you could give her a narcotic before she comes in, or you could give laughing gas, or you could do a desensitization therapy, or maybe even a rainbow wrap. You could do something different besides using Versed or benzos on aging patients.
How often do you use reversal agents, and do you see adverse reactions with them?
So in the beginning, I wasn't comfortable using reversal agents. I would just let them sit until they woke up. But I've had such great experience using flumazenil that I use it weekly. And it's usually those patients that I had to take that have a moderate disability, and I've had to take them a little deeper than I wanted. And so now their caregiver is back and it's time to go, and they're not fully awake. So if it's been an hour after their last dose of medicine and they're not good and awake, I'll give them a shot of flumazenil in the deltoid. I don't put it in the IV because it wears off too fast, but I believe if you do a sub-Q or IM injection of flumazenil, it will deliver up to an hour. So it works within 5 minutes and will continue to work when they leave your office, so the patient will be awake.
How much does the Hoyer lift chair cost range? I know most dentists will not pay for it, though.
And I have no idea what that costs. I'll bet you can get one on eBay though.
Let's see. Okay, the very elderly could also be considered special needs. It would be helpful to address these folks. For example, you cannot put your 90-year-old with COPD all the way back in the chair.
That's a great point, and I'm going to put in a slide for elderly patients and then talk about their specific needs, because that's a missing slide. So thank you for that one.
How would you alter sedation recommendations for elderly patients, and how do you deal with polypharmacy?
So almost all of the special needs patients that we have a variety of polypharmacy, and I would say don't let that scare you. Just look at the list and go through it. There are certain medicines to watch out for. They're not in use really anymore. The ones that might be a problem would be antiretrovirals that are used for HIV treatment. Some of these antiretrovirals inhibit the breakdown of benzodiazepines. So if you gave them a trazolam, it might not wear off for 6 or 8 hours. And that would be someone that is taking an antiretroviral. But I don't think the new combination drugs are doing that. I don't see really anything in all the polypharmacy that would make me want to not do it. I would just be aware of it. Things to watch out for when you have long cases, of course, are patients with insulin dependent diabetes or uncontrolled adult onset diabetes. Those are the folks that you want to schedule the appointments early morning if they're going to miss a meal, and you also want to check their blood sugar level too on your insulin dependent diabetics and have control over that. That's why we always have soft drinks, in the office, and some glucose if we were to have a diabetic crisis.